Hi, everybody, and welcome to the ILAE webinar on ADHD in children with epilepsy. My name is Colin Reilly. I'm a psychologist and work in Queen Sylvia's Children's Hospital in Sweden and also Young Epilepsy in the UK. I'm also the chair of the International League Against Epilepsy's Pediatric Psychiatric Issues Task Force. Today's webinar is about ADHD in children with epilepsy. Many children with epilepsy have co-occurring psychiatric difficulties, and ADHD is probably the most frequent difficulty we meet in our epilepsy clinics. So we have four speakers today who are going to talk about issues across the spectrum of ADHD in children with epilepsy, including the frequency and prevalence of difficulties with ADHD, screening and diagnosis, treatment with medication, and also psychological approaches. So if you have questions, please use the Q&A at the bottom of the screen, and we will answer the questions or try to answer them at the end of the webinar. So our first speaker today is Stephan Auvin. Stephan is based in Paris. He's a pediatric neurologist and he's chair of the Pediatric Neurology Department at the Robert Dubreuil University Hospital. His clinical and research interests focus on early onset epilepsies and also drug development in epilepsy. He has a long history of involvement in the ILAE and is currently co-chair of the Regulatory Affairs Task Force and a past chair of the Pediatric Commission. And he's currently deputy editor for Epilepsia, ILAE's flagship epilepsy journal. Over to you, Stephan.
Good morning, everyone. The first talk, I will share my slide. Then the first talk today, it's about prevalence and clinical presentation of ADHD in children with epilepsy. Then this is my disclosures. Then today, I would like to discuss the prevalence, but not only how frequent it is, but what is the clinical presentation and how it impacts your clinical practice. As an introduction, I will mention a few things that are quite obvious, but it's always better to be reminded about it. ADHD is the most frequent comorbidity in pediatric epilepsy, and the incidence of ADHD in epilepsy patients is higher than in the general population. We will go through more detail in the talk, but I just put this study from the past, 2007, showing the incidence in epilepsy patients compared to control. I mean, there is not very well conducted study on that, but because of the clinical presentation, it's most likely that a lot of ADHD patients, in case of epilepsy, are underdiagnosed. A part of that is because, and we will discuss that later also, that you can see in this graph that the inattentive form is the most frequent form, meaning they have ADHD, but not in the caricatural view of what we used to discuss as a child neurologist. Because a lot of children with ADHD without epilepsy, this is the hyperactive part that is the predominant symptom, and the family are coming to the clinic because they are exhausted, the teacher is exhausted, everybody is exhausted because the hyperactive part and sometimes the impulsive part. I put here that picture that is a novel, an old novel written by Comtesse de Ségur about a child that was making a lot of funny things, a lot of joke. And I mean, when you read this book, Un bon petit diable, is typically the history of a child with ADHD, an hyperactive form, with all the issues that they have to go through. What is important in this case, because we have to deal most frequently with a different clinical scenario, is that an early diagnosis and a proper management, that will be the part of this webinar today, it's a key achievement, of course, for academic achievement of the child, but of course, for the quality of life of this patient. Okay, let's move on. My task to do this talk today was easily facilitated because there is a systematic review very well done on the prevalence and the risk factor for ADHD in children with epilepsy. This is a typical method for systematic review, asking questions, using different databases, screening all the abstract, looking at the article, and then based on the content of the article, looking at the inclusion criteria, and then put all together to do some analysis. And from 6,533 records that were screened, they end up with articles that was included in the meta-analysis, that is 46 articles. Something that is important, first point, something that was actually very close to the Bruce Herman study, I put the graph in the first slide, the pool prevalence is around 30%. Meaning in children with epilepsy, about 1/3 of our patients have ADHD criteria. Something that is important, and you can see this in the graph, even if we have like some test here, is the fact that there is a lot of heterogeneity between this study, and that could also make issue on how to interpret some of this study. The heterogeneity is related to the method, how were diagnosed, if it was a formal diagnosis or if it was based on screening and then diagnosis, if it was using scale or score or only interview. Of course, the setting could be very different. Some of the studies were done outpatient clinic, some were done in the community, some of the studies were done in the in-care, that is probably a bit different kind of patient. And some of the studies were focusing on some syndrome, some on other, explaining all this heterogeneity, as you can see here. But we have this pooled prevalence that is probably the key message here, is the fact that 30% have ADHD. With this pool analysis, I just selected few points that are probably important. I put the p-value for the difference between the score, and then when it's read, it's reached significance, statistically significance. And then you have the number of studies that was included, the prevalence, and this is once again the test for heterogeneity of that study. Looking to the ADHD subtypes, you can see that the inattentive form is definitively the most frequent, followed by the combined, and followed by the hyperactive impulsive, that is definitively lower. And we have to keep that in mind, at least for diagnosis is something important. They have ADHD in a quiet way. Then if you're not looking for it, you're missing it. Then screening is very important, and it will be addressed during this webinar. Something also that was found with this meta-analysis is the fact that outpatient, inpatient, and committee and database study found different prevalence. I mean, of course, with a higher prevalence, when you see yourself, your patient, compared to going to community or to database, it's not a big surprise. You can see at the syndrome, nothing reached significance, even, I mean, there is a trend, and we know that some of this syndrome, called with the former name here, but childhood absence epilepsy is probably some syndrome we have really to screen this patient and select, that was called in the past benign epilepsy with centrotemporal spike, that is the self-limited epilepsy with centrotemporal spike. It's probably also a big part. But if you look at the general all epilepsy type, the prevalence is still very high. No difference, some patients start ADHD before epilepsy, and some it's diagnosed at time of epilepsy. And to be honest, we don't really know if it's always start before or if it is associated with. This is the meta-analysis with all the risk factors. Once again, I put in red all the risk factors that reach significance, in blue some of them that did not reach significance. You can see the number of the study and the sample size with the number of subjects that were included for each of these parts of meta-analysis. Something that I would like to stress here is probably some of these factors that are well known. Having a neurodevelopmental disorder is probably a risk factor. Having an history of epilepsy, having an early onset epilepsy, having more seizures than 4 seizures a year is a risk factor. Once again, absence and generalized epilepsy compared to others, and something that is also a risk factor that is very well known is the use of polytherapy of anti-seizure medication. And we know this risk. Even it's still unclear for some of these anti-seizure medication, which one compared to other, but we have clear idea, for example, and I will discuss that with valproate in the case of childhood absence epilepsy. One of these factors that was studied here is the epileptic form activity, and you can see that it didn't reach significance. There is a trend with a p-value of 0.7 with a large sample, at least 500 patients, and 5 studies included here. It's always something that is discussed, and I decide to address that. We know that in case of ADHD, and ADHD in children with epilepsy as well, we know that in both cases, EEG abnormality, epileptic form abnormality are more frequent. But the complexity between what is available from this data, between the EEG signal, the type of ADHD, the severity of the ADHD, the way to respond to treatment, is very unclear. We need better multivariate analysis to try to decipher what are the factors that are important or not important, and also maybe advanced neurophysiology to better understand what can be the generator of this EEG abnormality and if there is a link or not. An EEG cannot currently be used as a diagnosis tool of ADHD. And same thing, I mean, probably it will be addressed at time of discussion of treatment. EEG abnormality are not predictive when you decide to treat this patient to predict if they will be part or not part of this risk of seizure worsening using, for example, methylphenidate. Then EEG is for your diagnosis of the epilepsy syndrome, of course. It's not part of your follow-up for ADHD or for your diagnosis of ADHD. And of course, I mean, it doesn't mean that we have to stop that and not looking for it. We can conduct research, but in the clinical practice, currently, there is no really use of EEG for ADHD in children with epilepsy. Then just to finish, I would like to illustrate a case of a 6-year-old with starring episode daily, and then, you know, you record, the patient have no other history, no familial history, going well, making a good performance at the academic level. And then you record the patient and you have typical absences and making a diagnosis of childhood absence epilepsy, that is 10% of the pediatric onset epilepsy. Now the standard of care is very well established, and I would like to go through some of these studies that establish the standard of care, because this standard of care include evaluation of attention function. There is this old study from Closer, I mean, not that old, but now it's very well established. It's a randomized control trial where they look at lamotrigine, ethosuximide, and valproate. And after 4 months, if it was not a success, they randomized to other group of anti-seizure medication. They look at 2 endpoints. The primary endpoint, of course, was looking at absences. In this patient, you can see that both ethosuximide and valproate was more effective, you can see the percentage here, than lamotrigine. Then if you look only on efficacy, you have 2 drugs that you can look for. At baseline, in these 3 groups, ethosuximide, lamotrigine, and valproate, they found 30% of ADHD diagnosis. And at the secondary endpoint that was included for the sample size calculation was on attention function. And you can see that it's remained around 30% for the ethosuximide group, same thing for the lamotrigine group, but it's increased for valproate, suggesting that you're worsening basically the attention function in this patient. Putting ethosuximide as the first line treatment. Something that is interesting, because this is the endpoint at 4 months, and you might think, you know, maybe, you know, over time, because you control the seizures, these patients may improve. And this is the long-term study. They look at 12-month outcome of this study. And then when you look at attention function at baseline, I mentioned it, around 30% for all of them, no difference between the three groups. At the first time of the endpoint, 4 months, increase in valproate compared to lamotrigine and ethosuximide. And what is very important, I think is very meaningful for our clinical practice, at 12 months, the open extension study after that, you can see that it remained at 56% in the valproate group, but it also remained at 30% in the ethosuximide group. Meaning that even if you are controlled, and a significant part of these patients are controlled, ADHD remain present. Then that means that when you diagnose a child with childhood absence epilepsy, even if they are becoming absence-free, stable on treatment, then your next clinic should be a screening of ADHD because 1/3 of them continue to have ADHD. It might not be an issue at that time, but later on, they will remain with the ADHD, and maybe it will impact quality of life and academic performance. Then my conclusion for today, ADHD is the most frequent comorbidity in children with epilepsy. We know that we have a high prevalence, 30%, meaning 1 of 3 patients we are seeing in our clinic. We have to keep in mind that is a quiet way to have ADHD. In particular, when you're a child neurologist, most of these patients without epilepsy coming to your clinic, people, are exhausted by the child because of the hyperactive part. And maybe twist also our way to think about ADHD. It's not the way of our epilepsy patient to have ADHD. They are quiet, and if you're not looking for them, you will probably miss them. It's not established by a very nice study, but we can assume that because of this quiet way, we are underdiagnosing them because we are not looking in the proper way. Then if you're not screening, you won't diagnose them. And if you're not diagnosing them, you challenge the future for quality of life. Thank you for your attention. And I will be happy at the end to answer questions.
Thank you very much, Stephan. A great introduction to this particular webinar, and really nice segue to our next talk, highlighting that we need to think about screening these children. So our next speaker is Kirsty Donald. Kirsty is based in Cape Town in South Africa. Her research spans across the pediatric sort of brain development using imaging, genetics, and cognitive testing. She's going to talk about screening and assessment for ADHD, and we know this group of children often are underdiagnosed, so it's very important that we know the issues here. Over to you, Kirsty.
Thank you, everybody, for coming to listen to this really important topic today. What I'm going to talk about in my presentation is to cover some really important issues around screening and identification of children with behavioral problems in the context of epilepsy, but also to give you a little bit of perspective on some of the additional challenges that children growing up in low middle income country settings may have to the challenges for doctors and the challenges for families of children who have these conditions growing up in these environments. So I as Colin mentioned, I come from Cape Town in South Africa, and this is Table Mountain and the Neuroscience Institute, which is an amazing institution which is able to do fairly cutting-edge research in an environment where the conditions which are very prevalent in LMIC settings are we have that kind of balance of both of those things, and alongside a tertiary children's hospital. And so I'm very privileged to come from this environment and get a little bit of best of both worlds, so to speak. So I have no disclosures. So what you've heard a little bit about today already is that, as we know, that looking at global burden of disease studies, that there are millions of of people in the world with epilepsy. But that active epilepsy peaks at this age of 5 to 9 years, which is often when children also start school and when behavioral conditions become, start having a real functional impact on a child's life. So that in a way is a kind of, it's a sort of conflagration of important moments, both for epilepsy and for behavioral problems, such that it is really critical that we are thinking about the behavioral problems at the moment that epilepsy often becomes a thing for children and families. And that is difficult because, as you know, neurological conditions are always hard for families to take on. It's frightening seeing your child have a seizure. Often parents think that their children are dying. And so this becomes a very, it becomes a focus around the frightening moment of the seizure, and that the other things that may go along with the seizures often get less focus. And so as Stephan has already mentioned, if we don't ask, we're often not going to find that answer. What about low middle income country settings? Are things different here? So while we know that there are 65 million or more people with epilepsy worldwide, the vast majority of those exist in low middle income countries. The prevalence is much higher in these settings, and the risk of developing epilepsy during your lifespan is much higher in these settings. So why do we think that? Why do we think that to be true? So there's an increase in risk factors, adverse perinatal events, central nervous system infections, meningitis, malaria, as well as poor access to healthcare services. And why is this important? Because these underlying things can cause the epilepsy. And as we know, the epilepsy itself may have a causative role in behavioral problems, but the underlying conditions can also have, and probably more frequently are kind of causing both of the things at the same time. There's some combination, there's some relationship between those two things. And because we have so many secondary causes of both things, they are far more prevalent. So some of the impacts of this result in children who grow up with epilepsy in less resourced environments also being less likely to be identified. So, as you know, epilepsy results in families needing to access healthcare, and access to healthcare is often very tough in LMIC settings, and often travel is far, and people don't necessarily have their own transport, and there are fewer experts, and as a result, treatment of the epilepsy itself is less commonly. There's a much bigger treatment gap, and so the degree to which a family and a child's life is impacted by the epilepsy, even if there are treatable aspects to it, is lower, with a result in reduced participation in education and employment, and poorer quality of life, with increased risk of premature mortality. The stigma is also important, and I mean, while I think stigma is something which we struggle with across the world, it's not special to one place or another. It is a self-described very challenging aspect for people growing up and certainly in our setting. And psychiatric and behavioral disorders are two of the most common comorbidities in epilepsy. So we sort of having the double burden of higher prevalence of epilepsy, more children with with epilepsy as a condition, more children with behavioral problems without epilepsy, and the condition itself being higher with less access to services. So when we think about identification and screening, it has to be highly intentional in this environment. This gives you just a little snapshot. So this is a global burden of disease map, which demonstrates the share of population with developmental or intellectual disabilities. And as you can see, it's heavily weighted towards environments who have traditionally lower incomes. And this is really just to illustrate that, to illustrate how the higher proportion of conditions is mirrored in a negative way by the amount of resources available. And you can see particularly the African continent is very under-electrified as a kind of what's the word I'm looking for? A metric of general resources. The other thing which we tend to see in our medical services is that the children with more, so we tend to see in the hospital and in our clinics, children with more severe end disorders. So we only tend to see the children with the more severe forms of epilepsy. We tend to see the children with more severe forms of behavioral disorders. This is just a kind of head-to-head comparison of autism, in fact, which is, not exactly the same as ADHD, but the trend exists. Comparing the Simon simplex complex from the States with our clinic population, and we tend to have children who present with higher needs, as well as more a higher proportion of associated intellectual disability and behavioral and comorbidity problems. So it is more challenging to find the children and more challenging to diagnose them in sort of multicultural settings. So as you've heard already, and I won't go into it, ADHD is much higher in children with epilepsy than in the general population, and there is a bidirectional association such that children may present first with ADHD and also have epilepsy, so we need to be considering that in both directions. What are the risk factors for ADHD in the context of epilepsy? So do we need to look out for specific high-risk groups? It can be helpful. So there's an equal, the evidence suggests that there's an equal sex distribution of ADHD and epilepsy. So while ADHD on its own is more common in boys, amongst those who already have epilepsy, whether you are a girl or boy, it doesn't really matter in terms of your risk. Once you have epilepsy, you've got an equal risk if you're a girl or a boy. There doesn't seem to be a clear link between the age of epilepsy onset and ADHD. And children with epilepsy and comorbid intellectual disability are at a higher risk of ADHD, just like they are to any of the other kind of behavioral and developmental conditions. There is a link between poor seizure control and ADHD, but obviously there is there's less known about whether that is because the seizures are uncontrolled or because the underlying condition is more severe in that child, causing both uncontrolled epilepsy and poor behavior. In our context, we have a lot more untreated epilepsy because treatment the families haven't sought treatment, or it is not available in different settings. And so that is a slightly different scenario. And then obviously where there's a family history of ADHD, which is really increasingly we recognize that the common variant and rare variant risk for the behavioral disorders or behavioral conditions, including ADHD, are really an important driver in families. And so that's something to ask about. And that's particularly important in something like epilepsy and ADHD, where if we have families where the parents may be a little more impulsive and disorganized and struggle with attention and many of the kind of core features of ADHD, they're less likely to be able to keep appointments and be consistent with medication. And that is obviously very, very important. So how do we start differentiating? So there are certain epilepsies which may mimic attention problems and vice versa. So differentiating ADHD and absence seizures is often a question that people ask, and there are certain questions which can help, or kind of typical questions which can help differentiate these. Epilepsy tends to, so absence seizures tend to actually interrupt play, as in a child will have behavioral arrest during those moments. The tricky thing is that they can be very brief seizures. And so, you know, if you blink, you can miss them. And so it's not always as easy as that. Interruption by external stimuli, and we often recommend to parents that you actually try and touch the child to see if they can come out of it. And then obviously the inducement by hyperventilation, particularly hyperventilation in the context of an EEG is a pretty kind of gold standard if you're really worried and you can't work it out from a history perspective. ADHD, so sometimes the question is it intellectual disability or learning difficulties and epilepsy, or is it true ADHD? Is the child not paying attention because they can't do it, they can't do the work, or is it a true ADHD? And that often is actually quite difficult to test out, and actual more formal testing can be very helpful in cognitive testing and where that is available. Other things which we need to really think about include the sleep disorders. So when you know, it can be sleep is, you know, the most preserved, evolutionarily preserved aspect of life, really, across the board. And we don't do well when we don't have sleep. And sleep can be interrupted for a variety of reasons, including repeat seizures. And so really asking a sleep history is something that we often don't do, and can be very helpful in identifying problems and a potential contributor. Other psychiatric conditions such as depression or anxiety can also mimic ADHD in certain contexts. And so asking about, if you're concerned about those things, asking relevant questions around those psychiatric comorbidities as well. So the impact of not diagnosing the conditions is obviously vast. You know, you can have educational and vocational underachievement, and those are the things which are quoted most widely, and can have secondary psychiatric effects such as depression and anxiety, because, you know, children and families will have insight into the fact that they're not able to manage in the scenario, and they would like to. And so screening, diagnosis, and management as a whole is a really important part of the care of children with epilepsy. So how do we do this? And it's helpful to have a system, because if you don't, you know, it's like anything. If you don't have a system in your clinic of doing it in a regular way, and so that one is comfortable with the questions and comfortable with thinking about it, and not forgetting to ask the questions, it slips out, because as Stephan has mentioned, it's often a quiet problem, but it can have very long-lasting impacts on a child's life. So there is, given that a group of studies report that there's increased risk of ADHD from the age of onset, we really consider screening right from the time of onset, even if it is in the preschool age, but certainly by age 6, we should be screening. It's worth reviewing it annually, especially when the anti-epileptic drugs are changed. And obviously, I mean, goes without saying, avoid screening post-ictally, because obviously you're going to get skewed results. Key things to consider in the diagnosis: it's worth people getting ADHD training. So, you know, obviously, you know, some neurologists feel less comfortable about behavioral disorders, but, you know, this stuff isn't rocket science and one can get training. There are a lot of good training courses in ADHD, and we are currently developing training courses for healthcare providers at the primary healthcare level here, just so that it becomes quite normalized to ask these questions, and that there isn't shame and stigma around it. It's really helpful to use a validated ADHD rating scale that is based on the DSM-5, and it's important to use one that is validated in your setting. And so, making sure that you know what is validated and speak to colleagues, find out what is used most widely in your setting, because it's going to be different in different parts of the world. Listen to the parents and ask them questions, and obviously exclude other causes. So, you know, medical causes, things like iron deficiency anemia and lack of sleep and allergies that keep people awake and make them irritable and itchy and uncomfortable. Think about those things, because sometimes they can really be undermining. Even if there is ADHD, you're going to make things worse in those settings, and they're easily treatable. Management you're going to hear more about, but in terms of the ADHD, in terms of minimizing the risk of ADHD and the ongoing management of ADHD, things to consider in your choice of medication in these kids include understanding their cognitive profile, so you know what is learning difficulties and what is ADHD, so you're not treating the learning difficulty with, you know, stimulants, which obviously isn't ideal. Try to keep the number of medications as few as possible. As we've already heard, valproate may exacerbate attention problems, but in our setting, it is much more difficult to get consistent other medication. So it's something that we need to battle with. And obviously multidisciplinary involvement, especially for kids as they transition into adult life. So in summary then, you know, the prevalence of epilepsy is high, as we know, and there's a significant additional burden in LMICs along with the neurobehavioral conditions. There are numerous comorbidities with epilepsy, and ADHD is just one of them, so we need to consider it in the whole. Psychiatric and behavioral difficulties are really common, and we need to. There are challenges to screening and diagnosis and management, in fact, but that doesn't mean that we shouldn't be doing it. So follow the guidelines and try and work out a system which is fluent in your own environment, so that there isn't a barrier to entry in asking. If you know who you're going to refer to, if you know what you're going to do next, if you identify the problem, it's much easier to ask the question. Thank you. And here's my email address if there's any questions. Thank you.
Brilliant, Kirsty. Thank you very much. Our next speaker is Kette Valente, a pediatric neurologist and neurophysiologist from Sao Paulo in Brazil. Kette is chair of the ILAE Pediatric Commission. She's an associate editor at Epilepsy and Behavior, and also serves on the editorial board of Epilepsia. She's a professor who has published extensively on pediatric epilepsy, and particularly on co-occurring psychiatric conditions in children with epilepsy. Over to you, Kette.
Thank you, Colin. Thank you for organizing this webinar about this important topic. It's time to review this. So my task here is to address pharmacological treatment, and these are my disclosures. And the question is, what works? And what's the evidence for this? We have to remember that pharmacological treatment, we have strong and solid evidence from ADHD that pharmacological treatment is about the core symptoms, meaning attention, hyperactivity, and impulsivity, and as secondary outcomes, improved function and well-being. So the perfect scenario is to have the combined therapy, pharmacological and non-pharmacological treatment, paving the way for the next talk from Colin, that I think it will be addressing more the non-pharmacological treatment. So it makes total sense to think like this and to see that pharmacological treatment works better in earlier ages because we know that ADHD is a developmental disorder, but as long as we go without treatment, then we add extra layers of comorbidities. And we make things worse in terms of psychosocial outcomes. So treatment as early as possible. But what's the evidence that we really have from children and adolescents? I'm not addressing adults. We have some, less, but we have persons with epilepsy. And based on the task force for ADHD led by Stephan Auvin in 2018. I don't remember anymore, it was a long time ago, 2018. And we had class 2 and class 3 studies for methylphenidates, and the efficacy is 65 to 83, in average population 75 to 85. Atomoxetine 59 to 82, and lisdexamfetamine. We have just one study comparing with methylphenidate, and the rate of efficacy is quite low compared to that we have in the average population with ADHD in patients without epilepsy. At our numbers, there is a certain discrepancy. So let's see why. Well, we have one randomized controlled trials recently reviewed in Cochrane. I don't think it's really a randomized controlled trial, it's a quasi-experimental trial because we have only 33 patients. But according to this randomized controlled trials, there is a decrease in the rates of inattention and hyperactivity compared to placebo. And also there is a dose-related efficacy that was not corroborated later by other studies, but other studies will have only prospective observational studies. Regarding the harms, then there is no difference between methylphenidate and controls. But again, this is based on 33 patients. And when analyzed properly, we see that this study has a very high risk of bias for allocation and also for selection. There is a bias in selection. So then we have 8 prospective studies, and I kind of summed the number of patients, and we have roughly 213 patients already studied without overlap between studies, and the efficacy is 60 to 75%. The efficacy was similar both on inattentive and hyperactive, so there is no difference regarding the type and no association between those and improvement, the opposite of what was demonstrated by Gonzalez in that experimental randomized controlled trial study that is a class 2 study with high risk of bias. So this efficacy seems to be good, but again, it's lower than expected. That is the range, the normal range, as you see, 75 to 85. And either we have a lower efficacy in children with epilepsy, or we don't have solid studies in epilepsy as we have in children with ADHD. And I believe the latter is the right choice. And 2 studies from this prospective studies deserve more attention. One is controlled, not randomized and blinded, and the other is a crossover. But this crossover has only 10 patients, so it's almost a case series. And the controlled studies, the studies showed that patients that remained untreated, this was published after the guidelines for ADHD, had a rate of success of 42%. So the effect size here is low. The effect size usually is 0.8, not this 1 or 1. So it's very low. And what's happening here? Do children with epilepsy improve without treatment? Well, Perhaps when we look at the assessment, this is the right way to assess ADHD rating scale, one assessment that is designed for ADHD and not a CGI thing that's not designed for ADHD and will measure secondary, not primary outcomes. We have to see that there is an improvement of only 25%, not 50%. An improvement of 25% opens the window for a placebo. So we have to be careful with the tools, measurements, and rates. Regarding atomoxetine, we have 3 prospective observational studies that I should say 4. One was included in the guidelines, but I excluded from here because it addressed the time if the patients remained in the study, and they did, 42%, but not the efficacy. And there is a new one, so I included one that's not included in the guidelines. So we have 59 to 82%. They are all class 3 studies, and there is this one that was included, but as you can see, it used CGI. That's not designed for ADHD, only for improvement in a general sense. Regarding amphetamine, that is expected to have, it's a second line and sometimes a first line treatment with methylphenidate. The results are quite low. We have just one study from 2014 comparing amphetamine with methylphenidate in adolescents, not children, and we have 24% response. That's quite low as well. And symptoms worsening, there was no worsening of seizures, but as expected, the side effects, they are higher with any type of amphetamine compared to methylphenidate. This is something that we know. Regarding safety, and here safety is seizure worsening, I'm not addressing other side effects. I will address them later. Methylphenidate 0 to 18%, atomoxetine 7 to 9%, lisdexamfetamine, we don't know, not in children with epilepsy. And we may say this is quite low, so we should trust this. Well, I think that I showed that these results, these studies, they have a questionable design. The samples are quite limited. The measurements sometimes are not ideal for ADHD. So it's hard to say that anything like safety or efficacy we can base on this. For example, for atomoxetine, the risk of atomoxetine, that's not a psychostimulant. Let's remember that in general population is 0.1 to 0.2%. It's very low. So maybe we are overestimating the risk in children with epilepsy. And when you don't have a controlled group, or a group that is your control, we don't know if the seizure worsening is because of the drug or medication, or if it's because we have a fluctuation of epilepsy and drug-resistant epilepsies. That's the problem of studying epilepsy and any type of intervention without a control group and try to see seizure worsening. We never know if it is the natural history of epilepsy or if it is the intervention. So do we have enough to establish guidelines or recommendations based on what we have in ADHD and children? Hardly. We can establish consensus based on expert opinion, but hardly. I think we don't have still solid studies to say anything. We have some methodological concerns, as you saw, class 2, class 4, I think it's more class 3 and class 4, heterogeneous sample, no clear diagnosis of ADHD, sometimes just a screening, and then we are treating symptoms and not the disorder, which is quite different. The symptom rating, as you saw, scales and tools differ in different studies, so it's very hard to compare. And most studies are just open label observation cohorts and sometimes even case series. But do we have evidence from studies with persons? In this sense, I mentioned children and adolescents. We already have for adults too. with ADHD? Actually, we do. We just have to adapt. And we have guidelines for primary and secondary and tertiary care, and even some recommendation for parents and primary healthcare providers, not only doctors or physicians, for nurses and social workers and community. And we have guidelines based on evidence, such as the Australian and the American Academy of Child and Adolescent Psychiatry that was updated. And all of them have an agreement. Before we start speaking about drugs, we have to remember what they treat. And again, I will emphasize that they treat mainly symptoms of attention, hyperactivity, impulsivity. And we have some doubtful evidence for cognitive, meaning executive dysfunction. Because executive dysfunction will need some training and some rehabilitation. There must be an agreement. There must be a planning with the family. It's a shared decision-making. So the family has to be aware, and the adolescent, of the potential benefits and long-term effects, such as height, and the choice and dosage, because it's based on efficacy, not in milligrams per kilo. We have some limits, but the family has to understand that. Regarding assessment for EKG and EEG, let's stop with that. We don't need any type of screening with EKG and EEG for this type of treatment. Perhaps for blood pressure in adolescents that have a history of hypertension, in adults for sure. And if there is a history of congenital heart defect, then first there must be an evaluation by an expert. Just that. So completely unnecessary. Well, regarding the guidelines, nice, we have even a flow how we should treat, and then first line methylphenidate. If it doesn't work, lisdexamfetamine, and two psychostimulants, so always psychostimulants. And if it doesn't work, then atomoxetine. Guanfacine, I have to confess, I do not use. I prefer atomoxetine. I don't have too much experience with guanfacine or any other type of drug. It causes too much drowsiness. And according to the Australian evidence-based guidelines for children, adolescents, and adults and older adults, then there is no superiority comparing methylphenidate and dexamphetamine or lisdexamfetamine. I use lisdexamfetamine more than dexamphetamine, but I prefer always methylphenidate. And then a second line, a non-psychostimulant, because it is less effective. We may use atomoxetine based on personal observation, mainly in adolescents. Okay, what is the evidence that we have? Well, this is a very nice review, a systematic review of all reviews. And what we have a large amount of patients and randomized controlled trials showing symptom improvement, mainly the core symptoms. This is what I'm talking about, but also with methylphenidate, we have evidence for behavior and quality of life, and even for executive function. For harms, mainly sleeping and appetite, and mainly sleeping when it's used in the middle of the day, not in the morning. Appetite may be a problem. For amphetamine, what do we have? We have the same improvement in symptoms, but we don't have in behavior or quality of life. And of course, it has more side effects. The number of patients with problems with sleep and appetites is higher, is much worse. Also, abdominal pain. This is a common complaint, and tics occur more often with amphetamine. We have to remember that they may occur with methylphenidate. And for these patients that have as comorbidity tics or OCD, we prefer atomoxetine. So we have enough to say that psychostimulants, at least psychostimulants, they have benefits based on randomized controlled trials. There is a very nice Cochrane review with low risk of bias and high certainty of evidence. And in double-blind placebo-controlled trials, we are speaking about 75% of patients with ADHD, they are clinical responders. But if you use a nice scale for ADHD that can measure quantitatively rating scales, as I mentioned before, then the effect size is large, 0.8, meaning clinically that a child may have an improvement of 8% of his or her symptoms. And in a practical setting, in a practical meaning, clinically, this child that may be dysfunctional is transformed in a functional child. The carryover effect is always a concern. It is important to show that there is no carryover effects, especially for children and adolescents. The metabolism is faster. And here is a curve for adults. And the metabolism is slow, but in 24 hours, we have nothing. So I always tell mothers, this is the easiest medication to prescribe because it's the easiest one to discontinue. If we have side effects, you just stop and that's it, okay? And the side effects will stop and the efficacy will stop. We have no evidence to stop during weekends or not to stop during weekends. Particularly, this is based on my personal opinion. In higher doses, I don't like this switch in, on and off. It doesn't work for me. And I advise my patients to take from Monday to Monday, and with a possible break on holidays if there is a problem with height. The combined treatment and long-term treatment works. Combined treatment is the best treatment, is the multimodal treatment. It has already been tested in one of the largest randomized controlled trials, the ILAE cooperative group in 579 children. This study has these 4 arms, and indeed medication and medication plus behavioral therapy were better than behavioral therapy alone or treatment as usual. And was a long-term study, 14 months, and sustained the efficacy throughout 14 months. We already have studies with 2 years and 5 years. The efficacy was sustained. The effect size is high, very high. Risk of seizure. Well, regarding the risk of seizure, we had this alarming study published in 2020 that there was an increase in the risk of seizures, even in average population. And then looking at this study better, there are some concerns because we don't know these patients. Actually, we don't know if they were patients that were, they were children. Okay, so we had patients that would have epilepsy or acute seizures anyway. But even considering these aspects that were not analyzed, we have 4.4 per 10,000, which is low. And this increased risk of seizure occurred always in the first 30 days when you start the medication, but not later. So if you have in the beginning, not later, and with higher doses of drugs. But we have some reassuring studies, some studies that I like a lot. And if you have to read something, read this one. This is US, Sweden study. There is a lot of things coming from Sweden that are quite good, not only our co-chair and his papers, our chair and his papers. We know that the number of patients with epilepsy samples with ADHD is high. This is something that we know, and this was demonstrated in this populational study. but there was no difference between the risk of seizures with intervention and without intervention. So with 800,000 patients with ADHD, with intervention, there was no difference at all in the population level and individual level. And we also have this very nice manuscript from Sweden, again, from Isabel Brickel, showing in a national register based study with 995 individuals with a seizure history, not clearly if it's epilepsy, but seizure history, that initiated treatment and type of treatment, but there is a predominance of methylphenidate. They were psychostimulants, that there was no increase in seizure. As you can see, actually, there was, here is the treatment, no increase, and actually there was a reduced rate of seizures that we can postulate that is about adherence and compliance to treatment. Patients, when they are medicated, they will adhere to treatment, to the treatment for epilepsy, and then we'll have better results. But if you still have doubts about treatment, treat or not to treat, what about not to treat? What happens with these patients? Well, mortality risk is quite high in ADHD, is high in epilepsy, and is high in ADHD. So we are just, summing effects. And they die mainly of the same reasons that patients with epilepsy, unnatural causes, accidents, and suicidal behavior is also very high in older ages. And we have a lot of pharmacoepidemiological analysis from different countries showing that treating these patients, you decrease criminality, you decrease the risk of traffic accidents for boys and for men, you decrease the risk of injuries, and you decrease the need of emergency and hospitalization because of injuries. So I would consider to treat and decrease morbidity and mortality. So considering the pharmacological treatment, what works? Treatment works, and I think it's safe. Psychostimulants they are the first option, followed by non-psychostimulants, and in this sense, I would say atomoxetine. We don't have evidence for diets or anything like this. The benefits are very well established in the population with ADHD, and although our studies in epilepsy, they are not solid enough for recommendations that are strong, but still they show benefits. The risks, there is no solid evidence. And when I showed those studies about side effects, you saw that I mentioned appetite, I mentioned sleepiness, but I didn't mention seizures because these studies don't mention seizure, meaning it's not an issue. There is no solid evidence so far that psychostimulants or atomoxetine cause seizures or epilepsy worsening with treatment. Okay, so not to treat is worse, and the risk is great. So thank you. I'm always available, and if you have doubts and want to discuss, that's me. Thank you very much.
Thank you very much, Katie. Very reassuring, I think, to hear about that. The last presentation is on psychological interventions for children with epilepsy and ADHD, and I'm going to give that particular talk. So just to get started, here are my conflicts. So my talk is going to focus on psychological support for children with epilepsy and ADHD. I want to start off by talking about what should we expect and what should children and families with ADHD and epilepsy expect in terms of care. I'm going to talk about psychoeducation close to diagnosis or at diagnosis regarding the nature of ADHD. Planning, treatment and support. So as Kette was saying, making sure that our families, children and families can make informed choices about treatment and support. I will then talk about an area where there isn't actually a lot of evidence, but it's an important area. And I will talk about some studies in relation to evidence for treating ADHD or related problems in the epilepsy population. And it's important to say related problems because there isn't a lot of evidence for treating ADHD. But I'll talk about parent training, school strategies, programs or interventions which focus on improving executive functioning. So things like working memory, things like decision making, which are often impaired in children with ADHD. I will talk about computerized working memory training in the epilepsy population. And I will finish off by just mentioning why I think it's important to also consider transition issues for children with epilepsy and ADHD and summarize what we know in this area. So why is psychology important in supporting children with ADHD and epilepsy? We know that ADHD difficulties in children with epilepsy can significantly impact school performance, our own research from the UK, but also quality of life. In addition to difficulties with attention, children with epilepsy, they often have related difficulties. So things like executive functioning, behavioral regulation, metacognition. So these more executive functioning difficulties, which are often present in children with ADHD and epilepsy. And it's important to say as well, as Kette has rightly mentioned, that medication should not be the only treatment for ADHD, and particularly for younger children. The NICE guidelines recommend that ADHD-focused parent training should be offered first for those under 5 years of age. And it's very rare that children under 5 years of age with epilepsy would be treated for ADHD with medication. But even for those older children, it's very important that other supports are included in any package of treatment for children with ADHD and epilepsy. In the ADHD or in the epilepsy population, we do know that treatment for children with ADHD should include psychoeducational interventions and medication. So in the epilepsy field, it's the same as in the more general ADHD field, that psychoeducation or psychological approaches should be combined with medication. Just to talk about expectations and what parents and young people with epilepsy should expect in terms of care. I think it's very important, and Kirsty talked about before, that everybody's actually correct. Everyone is correctly diagnosed, so the child actually gets the right diagnosis in terms of ADHD, but also possibly co-occurring issues. And it's important, that young people and families understand the diagnosis and see it as a positive step to getting help and understanding from others. In terms of what Kette mentioned about shared care models, it's very important that we as health professionals listen to people's views. So listen to the young person and also their families in relation to what are the treatment options and help them get the most from their treatment. It's also important with checkups, so follow-ups. So whether or not they take medication for their ADHD, it's important that that ADHD is followed up, as well as obviously their epilepsy. And crucially, it's important that information is shared beyond the clinic, and that other health professionals and educational professionals actually get information about the child's epilepsy and ADHD diagnosis. So what do I mean, or what do I feel is important in terms of psychoeducation? And again, this is primarily at diagnosis, but it's very important this support is offered to young people with epilepsy and their caregivers. So it's important, to talk about how ADHD can affect their life. There are positive aspects, improving understanding of symptoms and identifying strengths and improving access to services. ADHD may be a route into extra support in school, for example. It's also important, as Kirsty has mentioned, that there may be stigma attached to a diagnosis of ADHD, and it's important that's acknowledged as well. It's very important that the family and child understand that there are certain environmental modifications that can actually reduce the impact of ADHD symptoms. So, for example, in school, particular adjustments and accommodations, such as extra time and adaptations to the classroom, might make a major difference to the child's education and quality of life. It's important to make the young person and caregiver aware that there are a number of options in terms of access to support support groups, voluntary organizations, but there are also websites and support in school. And it's important to think about the family and the child in terms of what sort of information or what form information should be given in, thinking about the child's developmental level, cognitive style, emotional maturity, and the cognitive capacity. Many children with epilepsy and ADHD will have difficulties with memory, processing speed, so it's important that they're borne in mind in terms of the dissemination or delivery of support in what form the materials might be, for example. And it is important that it's tailored to the individual's needs and circumstances. So in terms of planning treatment and support, I always think good treatment starts with good support. So understanding why they have gotten an ADHD diagnosis and their profile of ADHD symptoms. And Stephan has already mentioned that, with children with epilepsy, the inattentive form of ADHD is more common than in the normal or than the population who have ADHD without epilepsy. So inattention, difficulties with concentration, distractibility, all of these symptoms can lead to the child, having very significant difficulties, but often being missed. Hyperactivity and impulsivity isn't as common, but children with epilepsy, of course, can have the combined type of ADHD as well. And cognitive level is important here as well. And there's often a discussion on, what cognitive level, can one diagnose a child with ADHD? Can you, for example, diagnose a child with ADHD and intellectual disability? And I think it's important to say, particularly at mild intellectual disability and going into moderate intellectual disability, that ADHD is a valid diagnosis. And there is evidence, even in the epilepsy population, not very much evidence, but a study that was carried out at our centre in the UK showed that even children with intellectual disability can benefit from a medication for ADHD. And of course, it's always important not to stop at ADHD and to consider the child's strengths and needs, and consider that children with epilepsy often have a range of other co-occurring symptoms and sometimes conditions, including depression, anxiety, coordination problems, and difficulties in school. So these issues are common in children with epilepsy. When we looked at this issue in 2017, we looked at the group with ADHD and epilepsy and compared to just the epilepsy group alone, and there was a higher risk for developmental coordination disorder, so motor coordination problems, and oppositional defiant disorder in children with epilepsy and ADHD compared with just children with epilepsy. So again, really important to consider the full spectrum of possible conditions. So what can we achieve with psychological support in children with ADHD and epilepsy? What is the goal here and what are we aiming to do? And again, Kette mentioned this, but I think it's really important to say in terms of the psychological aspect, what we're trying to do is reduce the impact of symptoms on everyday functioning and improve quality of life. I think psychological supports probably are not ideal if you're talking about reducing the core symptoms of ADHD, but we can certainly do a lot in terms of reducing the impact of those symptoms and improving quality of life. And hopefully that might be in combination with medication. So where there is a little bit of evidence, in this population, and again, not always directly focused on ADHD, is behavioral strategies, including parent training. So this is, around parents, being trained to implement behavioral strategies and to sort of reduce the impact of undesirable behaviors. And quite similar in classroom management strategies, behavioral interventions, but also things like structure and accommodations. There's also some evidence for cognitive training, so computer-based training for working memory or executive functioning. And again, the evidence is very limited, and we must be cognizant of that. And it's also important, to consider advice around healthy lifestyle. Not saying that, dietary advice or physical activity interventions can, have a major impact on ADHD, but they're very important in a holistic approach. So thinking about good sleep habits, balanced diet, good nutrition, and regular exercise, that's all part of a holistic intervention for these children. So in terms of interventions in this area, I want to focus first on the MICE study, mental health in children with epilepsy. And this was integrating mental health intervention in epilepsy clinic. This was a randomized controlled trial in England and Northern Ireland. And it was for children with epilepsy who met criteria for common mental health disorders. And the MICE intervention itself, it's a modular psychological intervention designed to treat common mental health conditions such as depression, anxiety, or disruptive behavior, and children and young people using evidence-based approaches such as CBT and behavioral strategies or parent training. And the reason I want to talk about this study, because it does actually focus on parent training, which I think is often a very key aspect of intervention for children with ADHD who often have behavioral difficulties. And the primary outcome in this study was the strengths and difficulties questionnaire at 6 months post-randomization. So what were the results of the MICE study? I think the most important result was basically, and you can see in the graph here, that the control group and the MICE group were very similar in terms of SDQ score, so around 24 or 23 points for SDQ, so suggesting that the mean for these children was quite high. They had quite significant behavioral difficulties. The SDQ is a broad-based measure of behavioral and emotional difficulties. At 6 months, there was a significant decrease in behavior problems for the children in the MICE group, the red line, but also in the control group. The MICE group had a greater decrease. Now you might wonder and think, oh, the control group also reduced. So that probably suggests that actually undergoing assessment is very important, and young people and parents knowing about the nature of the difficulties is actually an important step. But at 12 months, you can see that the MICE reduction in symptoms was maintained and was a good bit greater than the reduction in symptoms for the control group. So MICE is an important study in showing that intervention using common behavioral and cognitive behavioral methods works for children with epilepsy. And the reality in this study was that many of the children benefit most from behavioral strategies, so strategies used by the parents. So it is important to say that, again, that good management starts with good assessment, and that behavioral difficulties can be reduced in epilepsy. And some of the children had intellectual disability, some of them had autism, but the effect was similar across those particular subgroupings. And as I say, many children with ADHD have these type of difficulties. So what type of intervention in terms of behavioral interventions did MICE employ? One-to-one time, so a parent actually spending quality time with their child. Active ignoring, so ignoring those low-level behaviors that children were showing, and actually the child learning, actually I'm not going to get attention for that, and instead I will get attention for praise, and I may get reward. So actually helping the parent understand what's an important behavior to ignore, what's an important behavior to actually act upon. But very important to have that positive aspect with behavior or with rewards and praise. Effective instruction, so actually delivering instructions to children in an effective way, being very clear about those instructions, being very specific, and that's really important for children with epilepsy who may have difficulties actually understanding language, or who may require very simple instructions. And timeout is also an approach that can be used in certain circumstances. So another approach that I want to talk about is a psychoeducational intervention, which we developed here at our clinic in Gothenburg in Sweden. And this is basically, informing children and parents about attention problems and letting them set goals in terms of how to minimize the impact of those attention problems, both at home and at school. So this is an intervention which we eventually delivered online. Originally it was in person, but because of COVID, we need to deliver it online. And this was a group intervention. The first 3 sessions took place in groups of 3 to 5 children with 2 psychologists. And the final session involved 1 psychologist meeting the child and the parent. And what was very important here was the child's teacher joined for one of the sessions. And we had positive data from this. Improvement was noted in all measures, and we had some significant findings in terms of executive functioning, health-related quality of life, and both the child and parent rated. And the feedback from the parents and the young people was very positive. They really enjoyed that we focused on attention, that we actually delivered it within the epilepsy clinic, and that they had the opportunity to meet other children with epilepsy. But what I wanted to sort of talk about mostly here was, you know, what type of strategies actually are useful for children with epilepsy and attention problems or ADHD in the classroom. And one of the first things that we often ask when we have meetings with schools is, where is the child sitting? You know, are they sitting near a window? Are they sitting near a door? Are they sitting at the back? It's very important that they're sitting in an environment where the distractions can be limited. So that's often up near the teacher. Sometimes these children will require ear defenders or headphones to sort of reduce the distractions from light, noise, and movement. They may need, you know, short periods of work interspersed with movement breaks and be able to say, I need a break, you know, and it's very important that, you know, instructions to these children are actually reinforced with visual, you know, or verbal instructions, that you actually repeat instructions, but also that you might write them down on the board in the classroom, but basically that the child actually has more than one channel, and it's not just a verbal channel or an auditory channel to receive those instructions. And a lot of times, some of these children will need one-to-one adult support, perhaps not all the time, but maybe to get started with an activity. So these are the type of things which we believe can benefit children with epilepsy and ADHD problems in the classroom. Another intervention which I think is very useful is this epilepsy journey. This comes from Avani and Modi's group in the US. And it's a sort of a computerized or gamified web-based executive function intervention in which the children themselves develop problem-solving skills to address the deficits by navigating through various lands. So it's a game-based approach, and it's focused on the components of executive functioning, such as working memory and problem solving. So a lot of kids with ADHD and epilepsy would benefit from this because they also have executive functioning problems. There was benefits with this approach. So caregivers and adolescents reported global improvements on the brief, a measure of executive functioning, and also behavioral functioning and health-related quality of life. So again, another approach in terms of improving the child's understanding of their difficulties and developing cognitive strategies to deal with those difficulties. In terms of, you know, what aspects were looked at, this comes from one of the publications. So problem-solving peak, mists of memory, positive thoughts, organization. So a lot of these issues are problems children with epilepsy have, but actually addressing them in a fun way and helping the children develop strategies to overcome these difficulties is really important. And again, like the space program, this particular approach showed very positive effects. There's also the possibility of working memory training. Working memory is not a core diagnostic criteria for ADHD, but many children with epilepsy and many children with ADHD would have working memory problems. This particular study evaluated the efficacy of a computerized working memory program called CogMed. It was an RCT, and it was, used with children with epilepsy. So computer-based training. The children completed computer-based tasks to try and improve their working memory. And it was found that there was significant treatment effects for the intervention group for things like visual attention span, auditory working memory, visual verbal working memory, and this was maintained after intention to treat and sensitivity analysis. At the follow-up, gains in these areas were usually sustained. I think it's important to say, and this is the concern sometimes with this type of training, that it may not always generalize beyond the core tasks that have been trained. So the intervention did not improve visual verbal working memory or fluid reasoning. So you tend to get, what you train. You train something and that gets better, and it doesn't tend to maybe generalize, but still may be a useful intervention for some children if you're looking at specific deficits and you're trying to improve specific areas. But there is that caveat that it may not be generalizable to sort of more general classroom activities. I want to finish my talk today about talking a little bit about transition for children with epilepsy and ADHD. A colleague of mine undertook a systematic review in 2022, and what we tried to do was identify the core aspects of what's really important for children with epilepsy, in terms of transition. And I think all of these 10 points are equally important for children with epilepsy and ADHD. It's very important to start early. to think about transition planning between 12 and 16 years. So that could mean something as simple as having the child, the young person, go to their doctor, at least some of the visit alone, and talking with the doctor alone. It's very important, and particularly important with children with ADHD, where there might be other doctors or other services involved. So it's important to think about different transitions. So not just the epilepsy doctor, but if there are other doctors involved as well, and that could be a psychiatrist or psychologist, but they also could be, for children with intellectual disability, other actors involved as well. Very important to meet the adult team before transition. Having one contact person, often a nurse, an epilepsy nurse, to touch base with through the transition process is very important. Very important to consider behavioral and emotional problems during transition, so including ADHD. It's not that common, but we have had children at our clinic at 16 and 17 who have epilepsy, have it for a while, and actually have not been diagnosed with ADHD, even though they fulfill the criteria. So it's very important at that transition period to consider those issues again. Very important that the child knows about their condition, both ADHD and epilepsy, so promote knowledge of disease and self-efficacy. It's important to discuss, parental involvement, and this will depend on the child's intellectual level, but oftentimes parents want to know, what am I expected to do on the other side, and have I still a role, or what will my role be? Important, and particularly with kids with ADHD and epilepsy, that verbal information is supplemented with written and visual information. Young people with epilepsy appreciate peer group support, and the parents also can benefit support. So this is very important, that young people with epilepsy can actually talk to other young people with epilepsy. And if that is the case, it'll always be certain that those young people with epilepsy have comorbid issues, and attention difficulties will probably be one of those issues. And it's very important that you think about the environment, particularly for children with cognitive impairment, and thinking about the hospital visits, the waiting room, and invitations. Okay, so just to summarize, good psychological support for children with epilepsy and ADHD starts with good assessment, considering ADHD in that assessment, but also other possible difficulties. And these co-occurring conditions, such as cognitive difficulties, autism, anxiety, they are also important to consider in planning support and treatment for the child. It's very important to help the child understand and family understand ADHD, but also understand ADHD in the context of epilepsy. We've already had some questions asked about, what is ADHD and what seizure, the effects of seizure. So it's very important to address those issues in any psychoeducation. And if medication is used, as Kette has emphasized, it's very important that it's used in combination with some of the psychological supports I've described. Support in school is vital for these children. Accommodation, so they might need extra time. They might need to take exams in a separate room. In the classroom, they might need to sit at the front. They might need extra support. They might need a distraction-free work environment. All of these things need to be discussed and implemented where possible. And it's very important to say that all interventions, need follow-up. We can undertake a study and see and show that particular interventions work, but do they work 12 months after the intervention? Do they work 18 months after? So they're really important to follow up with young people and see, are the supports that have been implemented still working? Is there a boost? And a lot of times the boost for me as a psychologist is having a new meeting with the school and just emphasizing the child's need for support. What supports does the child need? Maybe the child is a new teacher. So it's very important that those supports are available. Okay, thank you very much. And I'm going to stop sharing now, and we're going to go to the questions. Okay, I will see, is Kette still here? Kette, yeah. I guess we can look at some of the questions here and see. I have a question, Kette, which I think you might be able to help with. And the question is, what is the duration of treatment, when to stop, and the patient might be better after 6 weeks? I'm presuming this is the duration of the treatment with the ADHD medication.
Yeah, the thing is, you treat as long as the patient needs. And this is something to be discussed and reassessed, because we know that 30% of these children, when they get older, they will not have the same symptoms, or they become very functional. They don't want to use the medications anymore. So the only thing I say is that, or sometimes you just have a decrease in symptoms, and then they may try to, or they are in a different scenario, a different setting, more involved in things that they like, and then they may try to. I just try to make this transition in a way that they don't stop. They just stop and that's it. And they must have a follow-up. We discuss about. And you must treat as you treat epilepsy. How long do you treat epilepsy? You treat as long as the patient needs. ADHD is an invisible disorder, but it's there. I don't think it's so invisible because it has a lot of externalizing symptoms. When they get older, is more internalizing symptoms. So be careful to stop treatment. We always have to remember them of long-term effects without treatment. So there is not 6 weeks, or sometimes it's lifetime treatment.
Yeah, we're actually coming to the end of the webinar. So I'm just going to finish off by saying to Kette and all the other speakers, thank you very much. Thank you very much to the audience. We have a survey at the end, which Annabelle is going to put up, I think. So we would be very grateful if you could complete that. And it's important to say that a lot of the lectures we do, ILAE lectures, are available on the ILAE YouTube channel. So this lecture, but we have other lectures on autism and a range of other related topics from a range of experts. So go on to the ILAE YouTube channel and you will find some wonderful resources. Just to say thank you very much to our speakers, and thank you very much to everybody who was listening today. Goodbye.